Hi, everyone. Good morning. Thank you for that kind introduction, Jim. Our Institute for Global Health Sciences has been a proud supporter of the Global Health Economics Consortium for a number of years, and it's wonderful to see this audience today. You may be asking yourself what a global health guy is doing moderating a panel on U.S. single payer. I asked myself that same question. But I think it's important for us to remember that the United States is part of the globe, and global health starts right outside our doorstep. Makes sense. If we're serious about reducing health inequities, we have to think and act locally as well as globally. So thank you for the opportunity to moderate this panel, Jim. You've heard from Jim and Representative Jayapal about the potential for single payer to transform U.S. healthcare. And it presents a pretty stark challenge to many of the core elements that exist in our current healthcare system. That's a challenge we're going to have to grapple with today and thinking through the technical elements. Fortunately, there are a lot of lessons that can be learned from other countries that have their own models for universal health coverage. And we're very lucky to have two speakers today who will be walking us through some of the core elements of other countries' programs to see what lessons we can learn here in the U.S. First, we will have Joe Kutzin. Joe, if you wouldn't mind coming up. Joe is a health economist with more than 30 years of experience working on health systems, health financing in Asia, in Europe, and around the world. He currently leads the WHO's health financing team and has joined us from Geneva. So thank you very much for coming all this way, Joe. So Geneva is ahead of the Bay Area in fondue and healthcare, but that's it, right? And chocolate, okay, good. So we win on everything else. Thank you for coming. And then secondly, we will have Adam Gaffney here. Adam, thank you for joining us.
Thanks for having me.
Adam's a critical care doc with the Harvard Medical School. He works as a health researcher with the Cambridge Health Alliance, and he's president of Physicians for a National Health Program. And Joe will start us off by describing some of the core elements that exist in other countries, and then Adam will start to pivot towards more of the U.S. issues and the prescription for the U.S., along with what some of the health outcomes are that we might anticipate. We'll spend about 25 minutes or so in presentation mode, and then there'll be questions from the audience, so start to think about what questions you'd like to ask. With that, I'll turn it over to Joe.
Thanks. It's really, while we're getting set up, it's really, I'm very grateful to the organizers for inviting me to come back to this country. Yes, that's good. And to have a chance just to share a few ideas or reflections from international experience and how the U.S. fits in that context. And I think, as Colin just said, the U.S. is part of the world. And in fact, from where I'm sitting in Geneva, even though I don't have a Swiss accent, if there is such a thing, it is fair to say that actually what happens here does matter a lot for the rest of the world, not just for reasons outside of healthcare, but it has a lot of influence on what other countries do, what they consider, and so on. And I think it's important also to take some of the lessons from elsewhere and see how that reflects both in the policies and plans for reform here. First is an issue that is really, I think, at the core of this, which is what we call universal health coverage or universal coverage, and to say, what does that actually mean for public policy? And as we heard from the Congresswoman, one part of it, it means that coverage is a right. And coverage in this sense really meaning that everyone is able to get the services they need of good quality and without fear of the financial consequences of that. And beyond just a statement of goal or vision, it actually has important implications for thinking about the basis by which someone is entitled to services and thinking as well about the revenue sources, and we'll come to that in a second. And second, and again around the issue that I think comes up a lot in this country, and it does elsewhere, around fragmentation in arrangements, is that reforms really need to be assessed in terms of their impact on these goals at the level of the whole population. And when we talk about people getting the services they need, implicit with that, and I'll make it explicit, is the concept of equity. that that your ability to get services does not depend upon your income, your employment status, and so on. It really depends upon your healthcare needs. So we really try to assess these not just within one scheme or comparing one scheme to another, but across the system. And obviously, it's a very political agenda because you don't get there without some degree of redistribution. In other countries, that word is not a dirty word, actually, that is something that is seen as part of what governments are supposed to do. So with that as just introduction, just to say that what are some key principles, and I'll go through this quickly in terms of the financing issues. And I'll talk about each of these in turn, but first looking at how to, or relying mostly on public financing is one. Ensuring that policies around benefits and co-payments are really aligned with the goals, or especially around financial protection as well as the health goals. To address the problems of fragmentation, and fragmentation, as I said, is not unique to the US. It takes many forms, and it is typically an important driver of both inequalities and higher costs in systems. And then last is to say something about how services are paid for. We have this jargon of strategic purchasing, which really means that the way that money flows to providers is linked to some data on what the providers are doing, the health needs of the populations they serve, and also importantly, managing the growth of expenditures and not having open-ended commitments. So first of all is this idea of relying on public sources. And in other countries, you see a very limited role for voluntary health insurance. And what I would say is other high-income countries, for the most part. Limited private financing, limited voluntary health insurance. The other thing that's important is the idea of delinking coverage from employment. And there has been a history of that in a lot of European countries, in Japan and Korea, where most of the funding for the system has been linked to employment. It's a historical legacy. In their case, basically payroll tax funding. But over time, we're seeing a growing use of general tax revenues to feed into this. And really, it's about both the idea that, again, it's not just an employee benefit, but also, especially in countries with aging populations, that the share of the labor force in the population is shrinking relative to the overall population. And so you'd have to raise those taxes higher and higher to fund the whole system for everyone. And it really raises macroeconomic employment concerns and so on. So we're seeing this shift, and this is just an example from France, where they used to have a system that was predominantly payroll tax funded, and then starting in 2000 and a little bit more, they effectively broadened the base of taxation to move away just from wages and broadening more towards overall income tax as a funding source for this. I won't say that much about the voluntary health insurance, just 2 slides. And we say voluntary rather than private per se. I mean, that's a debate one can have, but there are examples in Europe of compulsory universal systems that are run through private insurance companies, as in the Netherlands or Switzerland where I live, and so on. But that's a distinction from voluntary health insurance, which has the core problems in a way of why there's such a field as health economics, which was the whole issues around adverse selection and market failure in health, so that those people who need coverage the most are progressively excluded from that coverage. And a real conflict, again, between what any one insurance scheme tries to do to maintain its financial viability and what is needed for the system as a whole. So this is a chart that just shows from 2015, in this case, the only countries in the world where spending from private voluntary insurance exceeds 10% of overall health spending. And the countries at the high end, what I highlighted in yellow, and South Africa is consistently the highest in the world, of nearly half of health spending coming from this source, which only serves about 15 or 16% of the population. And this is really a legacy of the apartheid system that has not really been addressed. All of these in yellow, it's kind of a Southern Africa phenomenon of the economic system that has not effectively been restored. The US was second at that time. And then in green, sorry, it's a little color coding. It's apologies to anybody who's colorblind, are high-income European countries. And what you see is most high-income countries do not rely very much on voluntary health insurance. So next, this is a bit of a complicated slide, also from my colleague Sarah Thompson, whom you'll hear from later today. This is now on policies on co-payments and benefits, and this is a study they did on a number of different European countries. And the main message to take away from this is that when you're designing, if you're going to, I mean, it's a question of whether you would have or not have co-payments, but if you have them, if you're not able to pay for everything for everyone, in a sense, then there's real issues in how you design them. And the countries on the right, the vertical axis of this is the incidence of catastrophic expenditures. So the higher the bar, the greater the percentage of households experienced catastrophic expenditures in these countries. And the countries in green on the left all have very protective mechanisms that essentially limit what people pay out of pocket. Those can be fixing co-payments as a fixed amount, having an annual cap on what they pay. In the context of France and Slovenia on the left, also having complementary voluntary health insurance that covers co-payments. The countries in trouble on the right basically define cost sharing as a percentage of the bill. And in a sense, the logic of that is that the sicker you are, the more you pay. And it almost takes a kind of accounting logic that there's some fixed 100%, whereas we kind of know it doesn't really work that way. So this is one of the key messages, is how you design these things actually matters. And summarizing that is to either have no co-payments or fixed low co-payments, exempt the poor if you have the means to do that, and regular service users, and put a cap on the overall level of co-payments. Some countries just take medicines and say, but people pay for more than medicines. So it is something that is feasible to different degrees in different countries, but this is really an important message in terms of design. On the pooling side, on the way that, in a sense, insurance funds are organized, there's very clear directions of what you want, and it's reflected, I think, in the Medicare for All proposal. You want your pools, I mean, the aim, in a sense, is you want to be able to redistribute from the healthy to the sick, and that everyone's in the same boat to some extent. So you want pools that are large, that are diverse in terms of a mix of health risks. That's why this idea of having separate high-risk pool doesn't really make a lot of sense, because you can't redistribute in that context. You just kind of are paying a large subsidy in that way. The real problem in this, again, is the fragmentation issue, which again reduces that capacity to put the resources where the needs are, and is also a key driver of high administrative costs and weakens purchasing power. And we'll come to that. I think a lot of the other speakers will talk about this. But just to say that what we see globally is kind of 4 different strategies to deal with this, because all countries to some extent have some type of fragmentation. One is to actually do what you're trying to do, I think, with the single payer, the Medicare for All, is just consolidate everything into one fund. And that's been done in some of these countries. Taiwan is a well-known, I think, example of that, but also Korea. Turkey has made that reform as well. In some countries, it wasn't politically feasible to do that, even if the reformers wanted to do that. That was the case in Mexico and also in Thailand. And so you kind of created a different insurance pool just for those who were not in the formal workforce. You have countries with a history of multiple competing insurers, and so in effect, creating a pool amongst all of them, so that even though there's multiple insurers, there is really one risk pool and one payment mechanism. And in Japan, where you have many kind of formal and compulsory insurance funds, like I think over 1,000, but there's, from the provider side, it looks like one payment system. There's unified benefits, unified payment methods. And the last key principle, in a way, is what we heard also from the Congresswoman, that you can't just spend your way to universal coverage. Right? And this goes back again to the idea of taking on the issue of, just letting, you don't decide that there's a sale on MRIs and you say, okay, I'm going to get one now, right? Or I could do, heart transplants are cheap or so on. So this is something we see everywhere. This idea of when you have fee-for-service systems, you get supplier-induced demand. You do have, I would say in the United States, and certainly in some low and middle income countries, not so much in high income countries, the idea, this conflict of interest problem, where actually providers own or have a controlling interest in diagnostic centers and then refer patients there and make money off of that. So this is also an issue. And when you have multiple payment systems, it really undermines your ability to use this mechanism to manage costs, because providers start gaming the system. They invest in unproductive administrative costs in order to do that, and they essentially weaken the incentives. And it's also an issue of equity as well, because then you get differences in benefits and so forth. So I'm supposed to bring international experience. I'm from the East Coast of the country, in case you can't tell, so I'm not that much of a foreign person. This is an old study from Pennsylvania, and is a great example of this, where basically you had a series of clinical practices that was largely serving two groups, a group of mine workers and a group of steel workers. And in one, let's say the steel workers, both of them had no co-payments. Then the steel workers, they introduced in their insurance scheme a 25% copay, and their utilization dropped. And for the mine workers, had no change in their copay, and their utilization increased. Right? So despite no change, and that was because the providers were losing income from the fall in one, and they were able to generate much more intensive service use in the other group, even though there was no change. So this was, again, one of the real problems of why not having a single payment system can drive a lot of problems. So there's a lot of very strong technical arguments for single payer. We'll hear about those today. I won't go into it much more. One thing I would highlight is that when you don't have a single benefit system for the country or a single payment system, it really weakens the incentives to invest in promotion and prevention, because the paying organizations won't necessarily reap the benefits of that. One thing that I just want to share, there are many different forms that this takes. And a single purchasing agent with a single set of benefits does not always mean a single fund. And you see very different examples here of how it's done. Sometimes it's multiple funds, sometimes it's one fund. The reasons for those choices are not technical. They're often historical legacies and path dependencies. But what they've done is started to move to unify things as best they can, given what their starting point was. And critical to all of this was a core universal benefit package. So I just want to say a few things, and as I said, I am an American abroad, not just because I'm from New York, being in California, but being in Switzerland. But to say what is different about this country from a foreign perspective, let's say. One is obvious, and this is a bit of a shocking picture, which on the left side is the percentage of the world's population divided across the US and then other high-income countries, middle and low. And on the right is the percentage of global health spending. And it kind of speaks for itself, but just to be clear, that this country accounts for nearly half of global health spending. Okay, so it's high. And obviously, going back to that message of not just being able to spend your way to universal coverage, this is really a concern in terms of just how high the spending is. So just quickly to wrap up a few things. In other countries, there is generally a constitutional requirement, or at least a public consensus, that there should be equal and affordable access to care for all. And that involves some degree of redistribution to put the resources where the needs are. The bottom point is really important, that the way that they finance healthcare does not have these kind of economic spillover effects, harmful spillover effects. And we heard it also from the Congresswoman about, for example, putting small businesses at risk if an employee develops an expensive condition, or putting in the way obstacles to people's choices about changing jobs or starting a business or so on, that you don't have that kind of distortion in the economy. It's also understood that governments have to steer markets, that it has to be public or compulsory funding, that they have to make explicit rationing decisions about what is and isn't covered. And they also generally allow those with the means, they don't prevent them from buying more things. It's just that the quality and comprehensiveness of the universal package is generally good. Unfortunately, here we have this very difficult starting point, a pretty poor public debate, and clearly no social consensus, not only on this, but on many other debates. So I would just say that it would be important to really focus the debate more on the goals than the means in this point. And this is just a guess from being abroad, but that what we want most of all is this statement in blue, presumably, that everyone is able to get the services they need. Their services are good quality and without fear of the financial consequences, not just for the payments they make, but if you can think about this now also in terms of the broader economy. There are some technical requirements, but at the end of the day, and my last comment is simply that there may be different means of getting there, and it would be very nice if we could go back to the days where the only disagreement we had was about the means and not the ends. Thanks very much.